So now that we're done with our part 3 of cornea, guys, let's start with the part 4, the last part, miscellaneous conditions. I'm calling them miscellaneous not because they are not important. I am calling them miscellaneous because they are just single topics which I can't group in anyone, right? So the first miscellaneous topic that I'll do is corneal dystrophy. Corneal dystrophy is a topic which students usually don't study in their MBBS days and neither in the pre-PG preparation days usually. I will not say that this is a very commonly asked topic, but yes, it is asked. It's not that it is not asked at all. So I'll be discussing it in brief and I will be trying to tell you some images and how you have to see them or how you have to diagnose them. Right, guys? So first of all, what we need to understand about corneal dystrophies, guys, is that dystrophies are primary corneal diseases. That means they straight away affect the cornea. They are not manifestations of some systemic disease or blah, right? They present usually in the first to second decade of life. Now, also what you want to know about corneal dystrophies is they are dystrophies. So I can say they are non-inflammatory. Yes. Then they are always progressive. The dystrophies will keep on affecting larger areas of cornea as we move ahead. They are usually bilateral and the inheritance pattern in corneal dystrophies is autosomal dominant. Okay. So these are 5 characteristics you can say about all corneal dystrophies. They're primary corneal disorders which are non-inflammatory, progressive, bilateral, autosomal dominant, and they present in the first to second decade of life. Now, below this, once we learn this, there is a table of all the names of the corneal dystrophies. See, there are lots of names. That is why we don't read it. So what I have tried to do is I have tried to simplify it for you as much as possible. The dystrophies are classified based on the layer that is being dystrophied. So as you will be able to see, epithelial dystrophy, Bowman's layer dystrophy, stromal dystrophy, or endothelial dystrophy. Okay. Let's look at one by one how to learn this, how questions are asked, and we'll keep moving on from there. Let's first of all see the epithelial corneal dystrophies. There are 3 main epithelial corneal dystrophies. You can remember the name by the mnemonic CML. Everybody, the tumor chronic myeloid leukemia, CML. That's how I remember these 3. So C for Cogan's epithelial basement membrane dystrophy. The most important point about this is the question that will be asked, it is the most common. Now I am not going to describe the clinical features and everything of all the corneal dystrophies. A lot of corneal dystrophies, even though they are present, they don't cause any symptoms or they are not important or we do not see them commonly. So I'm not going to discuss each and every corneal dystrophy. Cogan's, even though it occurs, the patient can pass the whole life without any sign being visible or without any symptom being experienced by the patient. Nothing to discuss. Okay. Cogan's is the most common. That's it. Period. Done. Now the second is Meesmann epithelial dystrophy. Meesmann, the first question, the difference from all the corneal dystrophies that we know, they should be progressive, but as is written here in one word, this is non-progressive. Yes. And this is specifically due to the mutation of a gene, which is marked here for you, keratin gene mutation. Now, due to this keratin gene mutation, the clinical appearance which occurs is characteristic. So I will show it to you, everybody. So this is a photograph of Meesmann corneal dystrophy. What are we able to see, everybody? Don't go on the red color. This is a photograph of the cornea clicked against the red glow of the fundus. Yes? Focus in this part, everybody. What are you able to see in this part? You are able to see some microcysts, very small cystic lesions. Yes? In the corneal epithelium. Okay? These microcysts contain some substance which is due to the keratin gene mutation. That substance is unknown, but yes, these cysts are formed due to the accumulation of that unknown material due to keratin gene mutation. This is Meesmann's corneal dystrophy, the image, and the 2 simple important questions that will be asked. Right? Now, let's move back, everybody. The last is called as Lish epithelial dystrophy. Again, please remember that apart from autosomal dominant, it can also be X-linked dominant. Nothing else is of significance here. Now, the second group of corneal dystrophy is Bowman's layer. 3 Bowman's layer dystrophies. You can remember them by the alphabetical order. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T. I hope you understand. R, S, T alphabetically. So Rees-Buckler's dystrophy, Schneider central crystalline dystrophy, and Thiel-Behnke dystrophy. These are the 3 important Bowman's layer dystrophies. Nothing much to discuss about them. Just remember whatever is written here, though still I think nobody will ask you this, so not going into the detail. Now coming on to the third dystrophy, that is the stromal group of dystrophies, which is the most commonly asked topic. Yes? So, number 1, L. L for lattice. I don't have any mnemonic for you to remember this. You'll just have to remember it like that. Lattice corneal dystrophies can be of 3 types. As you can see, type 1, type 2, type 3A. Whatever the dystrophy may be, in all the lattice dystrophies, the deposits of amyloid are seen within the stroma of the cornea. So to diagnose them, basically what we are trying to see, we are trying to see amyloid deposited within the corneal stroma. Yes. Now how do we see amyloid? We can either see it by PAS stain or we can see it by the Congo red stain. So let's see everybody. This is a photograph which has been given to you. This is obviously which stain everybody? Periodic acid shift stain. You can see an amorphous pink deposit here. Yes, this denotes amyloid. Or the better diagnosis is by Congo red stain. I hope you can see Congo red stain. Congo red stain, amyloid. I hope you remember from your pathology. Will give what everybody? Will give an apple green birefringence. Yes. So these areas, everybody, you can see, these are all amyloid deposits after getting stained on Congo red stain. Yes, thus making our life very easy and we are able to very easily diagnose these as a case of lattice dystrophy. So that's what I'm trying to say. Let's be smart. Let's not go into the details. Let's just try to learn here what the examiner is most likely to ask us. Yes. So deposits of amyloid in all the lattice corneal dystrophies stained by Congo red stain, apple green birefringence seen. Now, if we want to nitpick everybody, if we want to go into the details, what are the other questions which can be asked? Please remember that in lattice type 2A, neuropathy is seen. Please remember that lattice type 2 presents in the age group 70 to 90 years. Usually the age of presentation is first to second decade. So if they want to ask you a sort of a question which says which corneal dystrophy occurs in old age, then the answer will be lattice corneal dystrophy type 2, which is also known as finished corneal dystrophy. If they want to ask you another question, they ask you lattice corneal type 3A instead of autosomal dominant is autosomal recessive. I don't think they will ask you this, but still the information is written for you here. Now, let's move on to another important dystrophy. Gelatinous, just remember the name. Now, another important dystrophy here is granular corneal dystrophy. From the name, we understand that the appearance must be in the form of some granules. We will see the photograph. And then what is written here is that there will be what kind of deposit in type 1, everybody? Hyaline deposit. There will be what kind of deposit in type 2, everybody? Again, hyaline plus amyloid. What is common to both, everybody? Common to both granular is hyaline. So please remember granular is equal to hyaline deposit. So to diagnose, we want to see hyaline deposit. Now hyaline deposit is seen by which stain? The answer is Masson trichrome stain. Okay. Let's see the image, everybody. So this is an image of Masson trichrome stain. What we can see, first of all, the epithelium with all the nuclei in it, all this collagen in blue color being stained. But within the stroma, where there is blue collagen, we are able to see these pinkish, yellowish deposits everywhere. Everybody? So these are hyaline deposits. These are all hyaline deposits. So, hyaline deposits. I hope I'm clear. The stain is Masson trichrome and the diagnosis becomes granular dystrophy. No problem. Now we are saying granular dystrophy, granules. So what is the appearance like? So it is a very easily discernible dystrophy on slit lamp. We are able to see breadcrumb-like granules which are separated by clearly demarcated spaces in cornea. Okay? So you will see as if breadcrumbs are deposited throughout the cornea and the intervening spaces are absolutely clear. Okay? This is a characteristic photograph of granules on the cornea, granular corneal dystrophy. I hope I'm clear about this. There should be no confusion in this. Yes, guys? No confusion about this? Done? Let's move back, everybody. Now, another important dystrophy is M for macular. This is important because this is autosomal recessive and this is the least common corneal dystrophy. Am I clear to everybody? Autosomal recessive and the least common. Now, what gets deposited in macular corneal dystrophy? So, in macular corneal dystrophy, what is deposited is acid mucopolysaccharidosis. Okay. So acid mucopolysaccharides are getting deposited. So this is a form of acid mucopolysaccharidosis. This has been stained by Alcian blue stain. And upon staining with Alcian blue stain, what we are able to see, everybody, all the stromal collagen fibers as pink. But this is a deposit of acid mucopolysaccharides. Yes, giving us the diagnosis, very easy, very clear, that is macular dystrophy. Done? So what is important if you see? Let's just see again. Everybody. First of all, we need to remember the name of the dye. So Mason trichrome for hyaline. Then we need to remember hyaline deposits are seen in granular image. Again see, Congo red. Congo red means what, everybody? Amyloid. Amyloid means apple grain birefringence. And similarly, lastly here we see acid mucopolysaccharides by Alcian blue stain. The answer is macular dystrophy. Am I absolutely clear, everybody? So deposits of what in which type of stromal dystrophy and then the respective histopathological images. I hope I'm clear. Lattice, granular, macular. Please remember them. Now, moving on to the last group of corneal dystrophies, that is endothelial, everybody. The important is Fuchs endothelial dystrophy. From the name itself, it is very clear that the endothelium is getting affected. Yes? In this, there is a mutation of the gene which is called as COAX2 gene. COAX2 gene mutates, which leads to damage to Descemet's membrane and a little bit of endothelium. Due to the mutation of COAX2 gene, the Descemet's membrane and the endothelium get damaged. Due to that, the function of the endothelium and Descemet's membrane of the fluid entering the cornea is improper now, which leads to wart-like excrescences formed on the endothelium. Or if I try to explain it to you through a photograph, see everybody, this is my stroma here, should be no problem. This is my endothelium, which should be a smooth line. But now there are clumps of cells which are appearing as wart-like excrescences. Okay? So there will be these wart-like excrescences. Then there will be these clear spaces in between. Okay? This is known as cornea guttae. These are known as corneal guttae. And these are what are diagnostic of Fuchs endothelial dystrophy. Am I clear to everybody? There should be no confusion about this. That is the word written here, cornea guttae. Wart-like excrescences. Done, everybody? Then there are two others, posterior polymorphous corneal dystrophy and congenital hereditary endothelial dystrophy type 1 and type 2. Done? No confusion, I hope, everybody. Please just learn these important facts that are written in this table and simple photographs, 7 photographs that I've shown you along with simple explanations. Now, there are 2 other questions which can be asked pertaining to corneal dystrophies. What are the causes of recurrent corneal erosions? Okay. A lot of these conditions can lead to corneal erosions, obviously, because cornea is getting damaged, which are recurrent again and again, again and again. The mnemonic for this is CTRL1. CTRL means the control key on your laptop or your computer, guys. Yes. So C for Kogan, T for Thiel-Behnke, R for Rees-Buckler, and L1 for lattice type 1. Okay, everybody. So if you will see the table, you will again be able to see Kogan, Thiel-Behnke, Rees-Buckler, and lattice type 1. The second question is, what are the disorders of metabolism? So kind of list-based questions if examiners want to ask you. Disorders of metabolism. Even though it is written in the table, I'm just giving you a mnemonic again here, MMS. MMS. Let's go back to the table and let's see MMS, everybody. M for, first of all, Meesmann, right? Keratin gene mutation. Then M for, again, everybody, macular. And then S for, everybody, Schneider central crystalline dystrophy. MMS. Okay? Meesmann, macular, and Schneider. These are the three causes of the corneal dystrophies due to metabolic disorders. No confusion about this? Am I clear? Done? That's all about my topic, corneal dystrophy. If you ask me, sir, what is the treatment of corneal dystrophy? See, these are dystrophies. These are non-inflammatory. I can't give any drug. If any of these corneal dystrophies leads to substantial loss of vision, then the only treatment option usually that we have is keratoplasty or corneal transplantation. Done, everybody? Period. That's all about corneal dystrophies. So after finishing corneal dystrophy, continuing with our miscellaneous disorders, one-off disorders, everybody. Very important disease in itself that is called as keratoconus. Okay? From the name itself, I hope it is abundantly clear. We are talking about a cornea. Kerato means a cornea. And conus means something which is cone-shaped. Yes. This is non-inflammatory again. As a pathology, this is non-inflammatory and almost always progressive. And by virtue of forming a cone, it is classified as an ectasia. Ectasia means something which is causing the corneal thinning. Okay? If you don't understand it in simple words, let's just see a simple image. Let's just draw it. Let's say this is my normal cornea, which is convex. If there is shape abnormality occurring wherein the convex shape is slightly becoming coned out, we will call it keratoconus. As simple as that. Okay, everybody? Now, what are the important etiological factors, so as to say? Usually we say it is congenital, inherited, everybody. Okay? Congenital weakness of the cornea, which is leading to the thinning and thus the formation of the cone. Or we see it is commonly associated in cases of trauma, very commonly associated in cases of VKC, vernal keratoconjunctivitis. I hope spring catarrh, you know, in conjunctiva due to constant itching and rubbing. See, when I'm constantly itching or rubbing something, I am providing force for the shape to become abnormal. Yes? And then lastly, it is also seen to be associated or seen in children suffering from Down syndrome. Done? Now, what are the clinical features? Number one, please remember that the patient presents with visual disturbance. Why will there be visual disturbance? Due to myopic astigmatism. Why will there be myopic astigmatism? Please understand, everybody. Everybody, as soon as I have a cone, everybody, my axial length is increasing by some distance. Yes? If this was my normal eye, let's say, this was my normal axial length. When I have keratoconus, my axial length is increasing. Yes? Plus my corneal curvature is increasing. So axial length increase as well as corneal curvature increase both lead to myopia. The vertical curvature is changing, the horizontal curvature is not. So both the curvatures are different, so it is leading to astigmatism. So that is why I am having myopic astigmatism. You will be able to understand this only if you have read optics chapter, everybody. Otherwise, you'll have to go back to optics. Yes? No problem, guys. Very good. Now, secondly, everybody, if we say what is the hallmark, so on examination on a slit lamp, we see central or slightly around the center, paracentral stromal thinning, okay, which is always inferior to the center. Am I clear to everybody? Yes? So the thinning will slightly be inferior to the center. So the cone is always in the inferior part of the cornea. Done? Thirdly, the diagnostic sign I can say on torchlight, which a lot of you may have seen or examined in your clinical postings, everybody. See, the word is clinical. This is a case. You have to examine it. Munson's sign. What is Munson's sign, everybody? If I ask you, this is bulging of lower lid on down gaze. If you understand the fundamental of shapes, you understand this. Let us see how or what I am trying to tell you. Let's say this is my cornea. Let's say this is my upper eyelid. And let's say this is my lower eyelid. Okay, everybody? My cornea, behind that my whole eyeball. Okay? My cornea is convex. So is my curvature of the lower eyelid convex. This is my lower eyelid, everybody. Now, when I will look down, everybody, my eyeball will roll down. Convex structure like a ball, which will roll down and it will go below, or it will be able to turn below the lower eyelid. But let us see what will happen in the case of keratoconus. This is my upper eyelid. This is my lower eyelid. But my cornea is slightly cone-shaped. Can you see, everybody? Cone-shaped. Now when you try to look down, what will occur, everybody? This cornea, now I'm drawing it with green color. This cornea will roll down in such a place that the edge will get stuck over the eyelid margin. Yes? The edge of the cone is getting stuck over the eyelid margin. So when you try to look more down, the eyelid will also be pushed down. Am I clear to everybody? If you don't understand it diagrammatically, let's see an image. In this image, you don't understand the mechanics of how it works. But see, again the same thing. The apex of the cone has got stuck over the lower eyelid margin. And that is why it has pushed the lower eyelid also down into a bulge. Munson's sign. Okay? Just see this image. And if you want to compare it, see yourself in the mirror and see how your eyeball will go down. Right? No confusion about this. So this is an image of Munson's sign. Moving on, everybody. Let's see another important sign. Sign number 4. We call it Rizuti's sign. Okay? What is Rizuti's sign? Rizuti's sign is arrowhead of light seen over nasal limbus when light thrown from temporal side. Am I clear? Let's see the image. Everybody. This is a case of keratoconus. When we are throwing light from the temporal side, what is occurring, everybody? The light is getting reflected or refracted, you can say, from two angles or from two kind of, you can say, slopes. One superior slope, one inferior slope. So one light and second light going like this. So the light comes here, gets refracted, forms an arrowhead of light over the nasal limbus. This is called as Rizuti's sign. Okay, am I clear, everybody? Next, please. Sign number 5. On ophthalmoscopy, we see something which is called as oil droplet reflex. Very easy to understand, guys. The cone will throw a shadow. When you're trying to look at the fundus, the cone, the apex of the cone will throw a shadow in the form of a circle. And that is known as oil droplet reflex. Everybody see this? Because there was a cone, the apex of the cone is throwing a central shadow over the cornea. And this is known as oil droplet reflex. Done? No confusion about this, I hope, everybody? Clear? Yes? Now, moving on, everybody. Sign number 6 on retinoscopy. Something called as the scissoring reflex is seen. I know you like to see the photograph of this, but this is not at all identifiable in a photograph. This can only be seen in a video, everybody. I don't personally have a very good video of a scissoring reflex. I have not been able to record it, guys. Please just learn this name. Number 7. Due to the thinning of the cornea, there develop small fine breaks within the corneal stroma, which are known as Voigt's striae. Am I clear to everybody? No confusion? So, stromal stress lines, I can call them. Fine breaks, everybody. Now, once we know the clinical features, what is the investigation of choice? Everybody think about the special investigations we have discussed. Keratoconus is cone-shaped. That means it is an abnormality of shape, abnormality of surface. So which investigation should be used? Keratometry or pachymetry or topography? I hope the answer is clear to you. There should be no confusion. The answer is corneal topography. Okay, done? Clear? Now, after this, we should know the treatment. Number 1. The easiest treatment that you can do is rigid contact lens. Rigid contact lens, not the soft contact lenses that we usually wear for our myopias. There is a cone in the cornea. When I put a rigid contact lens over it, this will put pressure over the center. It will lead to flattening of the cornea. But it may lead to opacity. Am I clear to everybody? For a long time, obviously, number 1, it is not very easy to wear it. The patient has pain, the patient is uncomfortable, and then for a long time, because it is touching at the center, it is pressing it, opacity can develop. Secondly, everybody, you can do keratoplasty. Keratoplasty, corneal transplantation, change the cornea. That's the best thing. Thirdly, to prevent the progression and to stop it from developing further, the treatment that is done these days is known as C3R. So what is the C3R, everybody? Corneal collagen cross-linking. If you are understanding the name, you are understanding the way this works. In the stroma, the collagen fibers, they are being interlinked to give it more strength. There is congenital weakness most commonly, yes or no? So if I give the collagen fibers interlinking more strength, everybody, then this will stop the progression and even resolve it to a certain degree. Using riboflavin. Riboflavin is a photosensitizer vitamin. So riboflavin eye drops are put. After that, the eye is subject to ultraviolet A radiation, which leads to polymerization of the molecule and thus corneal collagen cross-linking. Okay, everybody, done? Please remember this name. Please remember riboflavin. Please remember ultraviolet A radiation. I hope I am crystal clear about this. There should be no confusion in this. Done, everybody? That's all about our simple pathology, that is keratoconus, a type of corneal ectasia, thinning leading to formation of a cone shape. Okay? Now, Let's move on to the next miscellaneous condition. A very small condition called as band-shaped keratopathy. Very easily explained through the image seen on the screen. Now, if you see the cornea is transparent except the center where it looks as if somebody had put a band-aid and removed it. Once you remove a band-aid after 2 to 3 days, you will see in a shape of a band-aid deposit, yes, wherever you had pasted the band-aid. So that's what it looks like. So there is white deposit. If there is white deposit, which is band-shaped, the first question which I will ask myself is, this is a deposit of what? White means calcium, deposit of calcium. Can I say in simple terms? Yes. Now if calcium is deposited, it is deposited in which layer? B for band-shaped, B for Bowman's layer. Okay. So how I remember it? Band-shaped, B for band, B for Bowman's. Keratopathy, K, calcium, K. Okay. Keratopathy, calcium. So Bowman's layer, calcium deposited. Okay. What is the treatment? Treatment is chelation with EDTA. As simple as that. It's the simplest treatment ever, everybody. You take an earbud, yes. You dip it in the liquid solution of EDTA. You roll it over the cornea, yes. All the calcium deposit will chelate and the cornea will become clear. That's what band-shaped keratopathy as a pathology is to us. Very simple to treat, very simple to identify. No confusion, I hope. Done. Let's move on to the next condition. Miscellaneous condition, arcus senilis. Again from the name, senile. Senile means old age. So this condition occurs in old age. Okay. What occurs in old age, everybody? Lipid deposition on corneal Descemet's membrane near periphery or in the periphery, whichever way you want to say. Senilis means old age, deposition of what everybody? Lipid, which layer everybody? Descemet's, and in the periphery. Now, that is where your diagnostic skills come into question. It is near the periphery. So a lot of students start saying it is at the limbus. Periphery of the cornea is near the limbus, yes. But that is the diagnostic sign of arcus senilis. Let's see carefully. This is my arcus. You can see the white deposit. Through red color, this is my limbus, everybody. So I'm marking limbus. This is my arcus. Between the limbus and the arcus, this green area, everybody, this is a zone of clear cornea. This zone is called as the lucid interval of Vogt. Lucid interval Vogt is a clear zone of cornea between arcus and limbus. Am I clear? That means to diagnose it as a case of arcus senilis, you should see carefully that the lipid deposition, the white arc-like ring, is not touching the limbus. If it is touching the limbus, then it should be some other pathology. Then you have to think about other causes of corneal opacification. I hope I'm clear here. No confusion. There is no treatment for this. This is an age-related change. Now, next miscellaneous small condition known as interstitial keratitis. From the name itself, it is very clear. Keratitis means inflammation of the cornea, and interstitial means between. So, inflammation only of corneal stroma. Okay? No other part of the cornea will be affected ever. Does not progress to involve epithelium or endothelium. Only the stroma gets inflamed. Interstitial keratitis. It is a specific condition with specific causes. The most important common cause that we encounter is congenital syphilis. The second important cause is something called as Cogan syndrome. You may have heard about it or read it in ENT subject also. Interstitial keratitis along with deafness Okay, these are the two main symptoms of Cogan syndrome. Then it can also be seen in cases of TB or in cases of herpes simplex virus. Okay, just remember two important things, only of stroma and congenital syphilis mainly, and other some simple small stuff. Treatment will be steroids because it is inflammatory in origin. No brainer here. Am I clear, everybody? Yes? Now, to finish the chapter of cornea, I will teach you keratoplasty. Okay, everybody? Another miscellaneous condition you can say. Keratoplasty, what do you mean by it? What is the literal meaning? Literal meaning is corneal transplantation. Corneal transplantation. You are changing the cornea. Now, keratoplasty can be divided into two broad types, full thickness or partial thickness. Full thickness is known as PKP, penetrating keratoplasty. Partial thickness is known as lamellar keratoplasty. Partial thickness I can further divide into two basic techniques. One is called as DALK. One is called as DSEK. Okay? What are the full forms? You will understand the names yourself, I hope. Deep anterior lamellar keratoplasty. Descemet's stripping endothelial keratoplasty. Okay? Just write out the names, just understand these names, and I'll show you photographs for these. Okay? Let's see the photographs, guys. If I show you this photograph, what have I shown you? That I am changing all the layers of the cornea from the epithelium to the endothelium. So I am calling it penetrating keratoplasty. Okay? When I show you the second photograph, DALK, deep anterior lamellar keratoplasty. So what am I transplanting, everybody? If you see carefully, I am transplanting the anterior layers. Okay? So what is being transplanted, everybody, in DALK? Epithelium up to the deep stroma. Okay? Whereas in DSEK, what are we transplanting, everybody? We are transplanting the bottom two layers. That is the Descemet's membrane and the endothelium. Are the photographs clear enough? In penetrating keratoplasty, all 5 layers. In DALK, the anterior 3 layers. In DSEK, the posterior 2 layers. So as to say. Are we clear about this from the names? Descemet's and endothelium. Descemet's stripping endothelial. DALK, deep anterior lamellar. Anterior means epithelium, Bowman's and the stroma. Am I clear to everybody? No confusion about this. Now, what are the indications for each of these procedures? Penetrating keratoplasty was earlier done in almost all the cases. But we say the most common indication is pseudophakic bullous keratopathy. Pseudophakic bullous keratopathy. Am I absolutely clear here? Yes? Then, DALK, deep anterior lamellar keratoplasty. This is usually preferred for acute hydrops in severe keratoconus. Okay, everybody? And DSEK can again be done in cases of bullous keratopathy. Am I clear to everybody? No specific indication for DSEK as such. I hope I am very clear about this. Now, once we know the types of keratoplasty, we need to know just a little simple information. How to do keratoplasty? Everybody, let's see this. So basically, let's say this is my cornea over this cornea, I have to first cut the host cornea to remove the damaged cornea. So we call this a trephine, everybody. You will be able to see the name written, trephine. This trephine diameter is 7.5 mm as written on the trephine itself. So the trephine is placed on the cornea and up to a certain depth it is punched. Either penetrating keratoplasty or deep anterior lamellar keratoplasty, whichever way. So this part of the cornea, let's say 7.5 mm, is cut and removed. Am I clear to everybody? So trephine will cut the cornea. Okay. Then what do? We implant graft cornea. We implant the graft cornea. Important point about graft cornea is its size should be 0.25 mm larger than host opening. Why is that so, everybody? Because after we put the graft donor cornea, we suture it, there will be some kind of contraction, everybody. So to allow for that contraction and the wound does not gape, we usually keep the graft corneal size 0.25 mm larger than the host opening. The opening is created by the use of a trephine, for which I have shown you an image. Now, so after keratoplasty has been done, this is the kind of image you will be able to see. See, 360 degrees sutures have been done. These are non-interrupted sutures. You could have put interrupted sutures, whichever way, everybody. There should be no confusion about this, right? So this is a post-keratoplasty image. Done, everybody? Now, after we have done keratoplasty, there are chances of graft rejection. Obviously. Now, the graft rejection can be due to problems in any layer, epithelial rejection, endothelial rejection, subepithelial rejection. The most common is endothelial rejection. Please remember this. Diagnosed by formation of something called as Khoda-Daust line. Again, nobody is going to ask you in detail, just remember simple stuff about this. Okay? Lastly, to end keratoplasty, what we should know, everybody, forensic topic, storage media. Number 1, short-term storage. Short-term storage is up to 48 hours. Okay? And it is done in what, everybody? 4 degrees Celsius moist chamber. Then intermediate term. This is up to 2 weeks. This is done in the McCarry-Kaufman media. MK media, popularly known as, guys. And thirdly, long-term storage up to 35 days. Though this is not to be done, still, if asked, the answer is cryopreservation. The cornea loses its viability to a large extent on long-term storage, even though we are doing it via cryopreservation at -70 degrees Celsius. Okay, everybody? Absolutely clear? That's all about keratoplasty in brief for you. That's all about my miscellaneous conditions, starting from corneal dystrophy, keratoconus, band-shaped and all that, and ending with keratoplasty. We are done with our cornea chapter. Again, I will say we have done 4 topics or 4 subtopics. Anatomy, special investigations, very important. I have explained to you. Corneal ulcer, very simple topic, and then some miscellaneous conditions. Cornea does not get asked too often in all the examinations. If asked, usually one question is asked from the chapter cornea. I hope you have been able to learn something. Right, guys? Done.